What do you think, Caitlin? Should we kick it off?
Kick it off. Yeah, let's do it.
Cool. All right. Thanks everyone for being here. Melissa asked me to step in to help facilitate, but clearly I'll need both Caitlin and Sasha to ensure that I don't mess anything up. I think we'll start with announcements. There's two that I'm aware of, but if others have some to share, please do. The first is that there are MSTAR presentations happening on Monday. There's the research poster session from 10 to 1 p.m. in the Guggenheim Atrium. So if anyone is able to attend, that would be wonderful to support our MSTAR students. Again, that's Monday from 10 to 1. And then the other exciting news is there was an extension to the Pepper Center funding applications for both the pilot and the research and education core. And that new deadline is now September. See, can't take me anywhere. I want to say it's September 1st. I will double check that, but I'm pretty sure it's September 1st.
September 2nd.
November 2nd. Okay, see. So please let folks know about both those funding opportunities. Send in applications. Any other announcements? Recent publications or projects that anyone, funding opportunities folks want to share about?
Just recently received a notice that the World Trade Center funds for a project, for 4-year project for looking at frailty is being funded by NIOSH. So Fred is going to be the PI, and myself and Catherine, who has just left, will continue to be involved and be multiple PIs.
Awesome, congratulations.
Yeah, thanks.
Any other announcements? Okay. Well, we have two exciting presentations. Are we good to go to presentations, Caitlin? Yeah, anything else? Okay. Two exciting presentations. Today is going to be the CAPC focused presentations. And our first presenter is Maggie Rogers, who is the Director of Research and Analytics at CAPC. And Maggie is going to be presenting her work on perceptions of palliative care program viability during the pandemic, qualitative results from a CAPC survey. Take it away, Maggie.
Where is the little, oh, there it is. Okay, can everyone see this? Looks great. Great. Okay, so Laura already told you what I'm going to be talking about today. I wanted to first just acknowledge the other folks that were involved with the project. So we have like a primary project team that did most of like the coding and all the themes and stuff. And that was Rachel, Julia, and Emily, who are usually on this call. And then we have we're writing this up, obviously. And so we have additional authors that also we utilize their expertise as well on the project. Bryn Bowman, who's the CEO of CAPC, Diane Meyer, and then Melissa, who is on vacation this week. Okay, so a little bit about CAPC before I start. This is important because this is really like a QI project for CAPC. And so I just want to give those of you that are not super familiar with what CAPC does a little background. So the Center to Advance Palliative Care is a national organization dedicated to increasing the availability of quality, equitable healthcare for people living with serious illness. We are part of the Brookdale Department of Geriatrics and Palliative Medicine at Mount Sinai. But we do have our own little group that works at CAPC. Oops. Okay, so CAPC does a few different strategies to reach our goals for culture change in healthcare. So first, we build tools that synthesize best practices and disseminate technical assistance to organizations that are trying to improve, like do exactly what I said, improve the care of people with serious illness. That does include specialty palliative care, but it's not always specialty palliative care. There are others that also obviously work with these populations. We empower change agents by equipping local champions with tools, coaching, and awareness to drive palliative care initiatives. We address knowledge gaps. We very much focus on like practical and person-centered ways to fill these gaps. And then last but not least, we think big picture, and we make the case to lots of different audiences. So payers, policymakers, healthcare professionals, and the public. And when Stacy and Eugene go, they'll talk more about the policy side. So the purpose of this project was in order to understand U.S. palliative care program priorities, especially around viability, meaning the survival of palliative care programs, and to inform future educational and program development, CAPC leaders developed and distributed a survey to palliative care program leaders across the United States. So what do we know about specialty palliative care program operations during the pandemic? Currently, we've been able to learn a little bit from single site write-ups. I know Sinai did one about the 24-hour hotline. There's been a few other places that have also written up what they did what they have done during COVID. And those things included providing direct patient care to patients with COVID, supporting caregivers and families, and then also providing peer support and guidance to other clinicians, so non-specialty palliative care clinicians, and communication skills, symptom management, coping with loss. We also know a bit about historic operational challenges pre-pandemic of palliative care programs, which included limited funding, palliative care program closures. We did a paper a couple of years ago talking about inpatient palliative care programs that have shut down over time, as well as a pretty well-researched workforce shortage and burnout issues. And so CAPC was very interested, especially right at the beginning of the pandemic, and as well as what we considered more of like a midpoint, was understanding what palliative care programs are doing, how their operations have changed, how they're feeling, are they burnt out, is there any concern about what's going to happen to the entire field of palliative care. So we distributed 2 online surveys via email. The first was in May 2020, so pretty early in the pandemic, especially if you realize that we sent it to a national list. So some places hadn't even really seen COVID cases yet, as well as January 2021, which was 6 months later. Our email distribution list contained 1,430 palliative care program leaders. 56% of the leaders belong to CAPC member organizations. So it's about half that were not from CAPC member organizations. So we were very happy about that, seeing that in our distribution list. The survey was developed through an adaptive process. It was really reflecting changes that were happening in terms of COVID between the 2 time points, as well as what CAPC was really interested in focusing on. The purpose of the survey was really to help CAPC understand how to meet the needs and understand what palliative care programs really needed during the pandemic. The focus of this presentation today is going to be about 2 specific questions that we asked in both of the time points. The first was a yes/no question. Are you concerned about the viability of your program post-COVID-19? And you can tell we use post-COVID-19 because at the time that was like kind of the language that people were using, thinking it would end at some point. And then the second question, which is a lot more of a focus of this, is to please explain why you are or why you are not concerned about the viability of your program post-COVID-19. And that was an open-ended question. And people wrote anything from 2 words to, a massive paragraph in response. So there was a very, very big difference in kind of like how much information people provided. So how we approached this, we did a qualitative approach. We did content analysis to synthesize into themes. We did it survey by survey. So we did we called these field surveys. We did the first field survey. Emily and I developed a list of a priori codes based on literature, what we kind of expected people to be talking about in terms of the viability and why that's happening. We reviewed a random sample, developed a code book, and then me, Emily, Juliet, and Rachel worked through the code book to do the remaining responses. And then we met to discuss, any differences in what we had found and refine what we put together. And then we applied that same code book to the second field survey. No new codes emerged. It was pretty much the same stuff that people were saying in the first one. People were just kind of iterating again in the second one. And we use those codes to synthesize into thematic statements. We kept detailed analytic memos and meeting minutes. And then we also utilized the experts from that second slide I show you who were outside of the project team to review and really add some color to the information that we had been collecting. So results. We got 440 total survey responses, which is a lot more than I was actually expecting from a voluntary online survey during a pandemic. The first survey we got 244 responses to, which is like a 17% response rate. And the second we got 196 responses, which was a 14% response rate. We did have 40 leaders that responded to both time points. So they answered in May and then they answered again in January 2021. We included them, and we counted them as two separate responses. The characteristics of the palliative care programs that these leaders were representing, half of them were administered by hospitals. They provided palliative care across settings, and many of them provided palliative care in multiple settings. So about 3/4 reported providing palliative care in hospitals. A half said they provided palliative care in home. A third in nursing homes. We also asked about like assisted living. There's a couple other categories, but these were the big ones. And then across the 4 regions of the United States, it was actually very well regionally represented, which was great because we know that the pandemic really hit in different places at different times. And so it was great to see that we got that kind of national participation. So what we found out is that 28% of palliative care leaders reported that they were concerned for the viability of their program, but the vast majority actually reported that they were not concerned about the viability of their program, which was kind of surprising. We thought there would be a lot more concern for the future of the field. And so we dove into the why or why not responses. And I'll present the themes that we found for leaders who were not concerned first, and then I'll talk about the ones for leaders that were concerned. So for leaders who were not concerned about the program viability, one of the first big themes is that the presence of strong leadership buy-in and service alignment with their organization's overarching mission and standard of care. For each of these, I included a couple of quotes that kind of add a little more detail to understand what we're talking about here. So leaders reported things like, we remain an essential part of the health system strategy for providing best possible care for our patients. We have strong leadership support for our program. They understand the bigger picture that palliative care is as an investment in the best care rather than a revenue generator. So these programs who were not concerned, or you could say were confident in the future of their palliative care program, it really had a lot to do with that strong leadership buy-in from their organizations that they sat under. The second theme was that the pandemic actually validated and accelerated the need for palliative care. This theme included lots of key phrases like valued, visible, and appreciated. Some quotes: the value of specialty level palliative care has become undeniably clear in the wake of a global pandemic. Our expertise, skill, and services have been invaluable to our hospital system and our community. Our program has increased both in census and how valuable the system sees us. We have more system support and recognition than ever at this time. The third is that these programs saw that they were very highly valued by their peers. And by peers, I mean both referring clinicians as well as others who are not working on the specialty palliative care team. So they said things like, we have an established rapport with our referral sources and administration. We've proven our worth, consistently support and provide relief to patients, families, and staff. We are working with colleagues to help prevent burnout, provide open forums for provider discussions and concerns. We are keeping our workforce healthy and viable. This was a very important theme because we often talk about palliative care's ability to meet the triple aim, but there is a quadruple aim, which is about workforce wellness. And so what we're seeing here is the palliative care team's ability to hit on that quadruple aim. And the last theme that we pulled out from those that were confident in their program's future is that they actually did, even though they were confident in what was going to happen to their program, they did experience and report some challenges. The two that came out were staff burnout and then limited program expansion. There was lots of write-ins, lots of little clips that hit on this, but the ones that I selected to show here, our palliative care bandwidth is stretched over capacity. I'm more concerned about staff well-being, retention, and capacity to provide care to all patients in need. If I had to worry, it would be that expansion and hiring is frozen all over. This will impact our ability to expand our program. So for leaders who were concerned about their program's viability, they said that they were not a top priority for their organization and were considered a non-essential service. If any program is going to get chopped, it would be palliative care. We are value added, but non-essential in their eyes. Palliative care is frequently seen as an optional service. A sub-theme of this is that issue of not being a top priority and being non-essential was compounded by the fact that they felt they had to continue to battle misconceptions about what palliative care is and what palliative care services are. Palliative care is somewhat new to the general public community, and the medical community oftentimes does not understand how a patient can benefit from palliative care. There's still big confusion on the services provided by the palliative care program. The second main theme was that the pandemic's financial impact on their administering organization heightened concerns. COVID is costing our system a fortune, and we were already strained financially. I worry that the cost of our program may be a target. With the cost of our organization as a whole, has encountered, some programs may need to be cut or downsized. A sub-theme of this is that programs also stated how they don't generate revenue as a palliative care program. They do provide cost savings for their institution, but the concept of revenue generation and cost savings are quite different, and they saw that it was very different in the eyes of their organizational leadership. The first quote said, "You can't cost save to profitability. Palliative care is an easy target for budget cuts in hard times." And the second said, "With the negative financial impact of COVID, there will be intense scrutiny of the need for the healthcare system to support non-revenue generating practices." And the last was a really big one, and this one was probably like the hardest to read through what people wrote in. But the reason why they were concerned about the viability of their program post-COVID was because their team is completely depleted and they were experiencing significant staff burnout. Even if we do survive from here on, we needed more resources before all of this happened, and the chances of us getting those are diminished. I also worry that our current team members are at the edge of burning out. I'm the only member of the palliative care team at the hospital. I've resigned under the strain of the program. Currently, there are no plans to open the position and replace me. And the last one, I made it really big. We are now overextended in several areas, and we are not able to provide excellent interdisciplinary palliative care in the areas where we currently work, all of which are seeing increased demand. I am personally feeling burned out, and as the main provider of palliative care in this small rural hospital with a loss of other staff and uncertainty about future staff, our sustainability is directly tied to my capacity. Okay. So those are the themes that we found from our survey. What we found was that the majority of palliative care leaders who responded were not concerned about the viability of their palliative care program. They cited things like strong leadership buy-in, their highly valued provision of support to colleagues, and the pandemic's positive impact on their services, visibility, their perceived value, as well as the utilization of their team. And both groups, both those that were confident and those that were concerned, reported the importance of value to leadership, different directions for each of them, but the value of their program to leadership, as well as their concern for burnout and workforce shortages for specialty palliative care. Some limitations, this is not generalizable to the perspectives of all palliative care leaders across the country, nor is it generalizable to frontline palliative care staff. This was just sent to a very specific list of palliative care leaders. And it wasn't an inventory of all palliative care leaders in the United States. It's descriptive. It's not intended to reflect correlation or causation in any way. We distributed the surveys during a global pandemic, which may have impacted who responded, when they responded, and how much they were able to contribute in their responses. And we collected very limited data on the palliative care team, the program structure, or the respondents themselves, because palliative care leadership encompasses many different people, from a clinical lead to a program manager, to a section chief. So implications of what we found. The first is that leaders need resources to develop and maintain strong relationships with organizational leadership and referring colleagues. The second, efforts to educate healthcare administrators about the value of and business case for palliative care. This is something that CAPC does regularly, but I do think that we need to possibly revisit some of our value pitches for palliative care in the context of COVID. The third is that we need methods to measure and quantify the impact of peer support provided by the palliative care teams. We see people saying that they're able to support other referring clinicians. We're able to meet the quadruple aim, but it's not really something that can be measured and quantified at this time. And then we need policy to prioritize efforts to expand and support the palliative care workforce. That's something that CAPC has been working on for a long time, but it's a very, long, slow, uphill type of battle, especially when all areas of the healthcare system now with the pandemic are feeling burnt out and experiencing workforce issues. Because this was a QA project for CAPC, I did want to point out some of the things that CAPC did and developed as a result of what we learned. So the first is that we developed a toolkit, which had three main kind of focus areas. The first was to understand the external environment and its impact on healthcare organizations and key stakeholders, engaging program stakeholders and aligning program services with stakeholder priorities and management practices to ensure efficient use of program resources and high quality care delivery during a period of instability. And this toolkit was a lot more focused on specialty palliative care. And then the second is that CAPC started offering virtual well-being debriefings that were facilitated by trained moderators. These were open to both palliative care professionals, but as well as anyone providing care for patients with serious illness, and they were free for people to attend and confidential. And that we also disseminated debriefing facilitator training materials so that palliative care professionals can host sessions with colleagues at their own organizations. So kind of like a training the trainer kind of model for debriefings. And that is the end.
Exciting work, Maggie.
Sorry if I spoke really fast. I just wanted to make sure that I was able to get through everything.
Does anyone have any questions for Maggie?
And I can do this so we can all stare at each other.
Yeah. Hi, I do. This is Henry Sachs. Very nice job presentation. What I noticed, I thought, was that a couple of the sort of saddest comments seem to come from fairly small institutions. And I'm just wondering, was that a general relationship? Is that part of sort of the general struggle of small hospitals, or what do you think? Was that a pattern? And what do you think?
It could be, because we didn't collect a lot of information about the institutions that were responding. It could just be that the small ones are the ones that mentioned it and maybe the others didn't. We didn't necessarily pull that out as a theme. And I would say generally, probably our responses were a lot more urban, large centers responding, because that's who CAPC typically knows. But there were, I think it's a good point, because there were a few responses about being rural in particular. And we did code those in terms of the patient population and service area served. I'm not too sure about small institutions. I think that small institutions have always had issues supporting like a full-blown interdisciplinary palliative care team because they don't have the resources to do that. And that's something that was documented before the pandemic and probably made worse by the pandemic.
Harriet asked a similar sort of follow-up question to that. Harriet, do you want to ask it directly?
Yeah, hi. Thanks, Maggie. I just wondered, I think the answer is probably no, and you probably already addressed this, but did you have the sample size to kind of do an analysis of these factors that are associated with kind of concern about program viability? Is there any work planned to kind of look at those that didn't survive the pandemic and try to understand at a kind of quantitative level kind of what these factors are?
Yeah, for this project, it was very much focused on the qualitative analysis of the responses. And a couple years ago, Melissa and I did a paper on adoptions and closures of hospital palliative care programs. I think it would be very, very interesting to repeat that study in a couple years. We all know that big national databases are always like very behind in how many years they are. For that, we use the AHA database, which right now we have 2020 is the newest. So I think a couple of years down the line, it would be very, very interesting to look at institutions where palliative care programs closed, especially if they had, and we could look to see if they had palliative care pre-pandemic and then post, whatever those kind of time delineations end up being. But I think it would be really interesting to do that. And for that, we could look at all of those factors, you know, size, ownership, region, rurality. We can look at all of those things about the hospitals.
And you could also look at whether they were expanded in the wake of the pandemic as well, because they got more visibility, etc. And I think there's something maybe interesting about cost of living and recruitment of faculty to support and people to support these programs, and how is that going to play out in the next 10 years? So
Totally.
I think we have time for one more question if anyone has one. Stacey also shared in the chat that debriefings are still ongoing, and there's a link there for folks to access them.
Thanks, Stacey. Yeah, if you guys have not checked out some of the stuff that CAPC has developed about COVID, it might, not for the research angle, but if you do also see patients, there's a lot of resources that would probably be really helpful.
Okay. Before we move on to our next presenter, Caitlin has a hot off the press announcement.
Yes, coming in on behalf of Stephanie Chow, there is a QI workshop this Thursday on Zoom from 3 to 4. I believe Sasha sent out an email about it already. I'm sticking some more details in the chat. It is designed for beefing up skills for fellow projects, but you definitely don't have to be working with a fellow. You can be anybody and attend. I'm going to go, and it sounds like it'll be fun. That's this Thursday, 3 to 4.
Great. So our next presenters are Stacey Sinclair, who is the Associate Director of Policy and Care Transformations at CAPC, along with Eugene Russin, who is a research scholar, associate research scholar with the Solomon Center for Health Law and Policy. And they're going to be presenting their work on the introduction of to the palliative care GPS. So welcome, Stacey and Eugene.
Thank you so much. We're happy to be with you today. I will go ahead and share my screen. All right, so as Laura mentioned, we will be talking about the palliative care policy GPS, and I am so thrilled to have this partnership with Eugene and the Solomon Center for Health Law and Policy at Yale Law School. This has been the work of a few years, and it actually came about in part because Dr. Meyer was invited to speak at the Solomon Center a while back, and I think she lit the room on fire to the point where I think folks were like, we just have to do more on this palliative care thing. So it's really been wonderful to work with the Solomon Center on this work. And I think to Maggie's point, part of what CAPC is doing, our mission to ensure that everybody living with serious illness has access to high quality care. And part of that is yes, training, yes, capacity building, but also the ability to deliver good care only goes so far as there is in a supportive environment to deliver that care. So do we have enough trained clinicians? Do we have the payment models needed to support that care? Do we have the quality measures? Do we have the accountability mechanisms? And so the palliative care law and policy GPS is our attempt to start to pull together information at the state level. So Eugene, I want to toss it to you just to introduce yourself and say hi.
Thank you so much, Stacey. It's such a pleasure to be here. This collaboration has now been going on for a few years now, and it's been just a total pleasure. Everyone here at the Solomon Center for Health Law and Policy at Yale Law School, which is our kind of flagship health research center at Yale, has been totally thrilled with this. And Dr. Meyer really did light up the room when she presented, leading to this presentation. So it's we are looking forward to the future of this, and can't wait to talk about what we've done with all of you today.
Thank you, Eugene. All right, so just I was going to give a little bit of overview about, why are we taking the policy lens and where does public policy show up in healthcare writ large? And some of you may have seen this when we presented on federal policy. So public policy shows up obviously in which healthcare services are paid for and how much they're reimbursed for and which patients are eligible to receive them. We mentioned quality measures and reporting requirements, access to public insurance through Medicare, Medicaid, also the Children's Healthcare Insurance Program, and then also parameters for how private insurance can operate. Public policy also dictates rules around care delivery, issues like drug pricing and funding for public health initiatives, the opioid epidemic, public health emergency spending in COVID, and so on. And so public policy really does have an outsized impact on how care is delivered and how much providers can and cannot do. In the past, we've talked about federal policy, and certainly the federal policy, it's a huge policy environment, but in recent years, we at CAPC have been increasingly interested in the state level policy, and in part because the federal policy can be a little locked down. It feels like change is really slow. It takes a long time to get important changes made. And a lot of the changes are operating at a very high level, whereas at the state level, there are a lot of levers available to state policymakers in terms of all of the issues that we care about. And then there is also a better understanding of what are the local needs and opportunities, and a better, more on the ground understanding of how to get things done. So when you're looking at the state health policy structure, there are a lot of parallels to federal policy. You're going to have a legislative branch, an executive branch, and judiciary branches. At the state level, that's where you're going to be seeing the oversight of state Medicaid plans, including Medicaid managed care and long-term services and supports and CHIP. Also post ACA, the state health insurance exchanges, a lot of them are run or overseen by the states. Certainly a lot of public health initiatives happen at the state level. And then a big one is state licensure requirements. And as I mentioned, in addition to the reasons that I said before on why we would be focusing on state policy, there's also been a trend over the last several years that the federal government is increasingly shifting risk and responsibility for healthcare payment to the states. Unlike the federal government, states do have requirements to have a balanced budget. And we've just seen that healthcare spending, which currently occupies a third of state budgets, if healthcare costs can't be contained, that will continue to grow and grow. And when that grows, it's a fixed pot of money. And so that starts to crowd out spending in other areas such as education, transportation, infrastructure, like other things that are really important for states to be attending to. And so, part of it is that states really are seeking innovative solutions to be able to contain the cost of spending, but also they're beholden to their residents. And they, I would say that a significant proportion of policymakers and state officials are in it for the right reasons. I think there's a lot of negative attention, but I think people do want to do what's right by their residents, by their constituents, to make sure that the dollars that they are spending and putting out are being used in the best way possible. So that's, there are some powerful incentives for why states are looking at how to address healthcare spending and how to do it in a way that's better. What are some of the levers that state policies or state officials have to improve access and quality? Obviously, we talked about the regulation of healthcare, regulating clinicians, facilities, insurance plans, contracts with Medicare Advantage dual eligibles. Purchasing power. States are huge purchasers of healthcare through Medicaid and then also employee and retiree health benefits. Governors, and they have their bully pulpit in terms of being able to point to say this is something that we should care about. And so obviously you saw governors wielding a ton of power in the COVID era to create executive orders that changed how healthcare was delivered. Special health initiatives that states can initiate, like public health and provider education initiatives, and being able to help improve health and healthcare at the community and population levels, and then market competition and consumer choice. So states can facilitate access to services for special populations and increase consumer awareness. And so as states are looking for innovative solutions, obviously we know that palliative care fits in there. There is a ton of evidence to support that palliative care can help improve people's quality of life, the quality of life of people living with serious illness and reduce their symptom burden, that they report high satisfaction with the care delivered. And then whenever we're speaking to policymakers, we always emphasize that cost savings are a byproduct of the better quality, but they do exist. And so some data to support the avoidable spending and utilization in inpatient, outpatient, skilled nursing, and home-based settings. And so we have, with this improved value case and the pressures that are confronting state officials, we have seen an increasing amount of activity at the state level. Thanks in large part to the leadership of the American Cancer Society Cancer Action Network. They've championed state advisory councils, passed legislation in over half the states to create these public bodies that serve in an advisory capacity to educate the public on palliative care. Some, in many cases, do a landscape survey to understand where palliative care exists in the state and then come up with recommendations to inform state officials on what is the next right thing to do. Palliative care has been included in a number of state cancer plans, which is a program from the Comprehensive Cancer Control Program. So you'll often see that coming up in survivorship, that as a part of the survivorship goal, that advancing access to palliative care is one of the strategies put in there. Several states have created, well, a few states have put in public awareness and information campaigns, New York being one of them. There are a handful of states that are now starting to walk the path of payment to say, there are plenty of Medicaid beneficiaries living with serious illness. Their care is fragmented. These are dollars that are not being spent efficiently. How can palliative care benefit or payment for palliative care services help us meet our goals with Medicaid beneficiaries? The heterogeneity of what is palliative care in the state level exists in the field as in policy. And so we've seen a few states work to create a definition of palliative care. And then we've also seen some requirements in education and training. A few states have palliative care specific CEU requirements, but more we've also seen requirements on learning more about opioid prescribing or pain management or communication. So some of the components of palliative care. So this is, as I mentioned, this is the most recent map from ACS CAN, excuse me, of where advisory councils have been established. The green is the states that adhere to the sample legislation that ACS CAN championed. Yellow is states that have programs that closely align with the main tenets of the model. And then the red state the states in red, not red states, are those that don't have an ACS CAN inspired program, but like may still have some work ongoing. For instance, we know that California has done a ton of work on palliative care and has plenty of champions who are working. So just because it's in red doesn't mean that there isn't that kind of activity happening, but it's been a very successful legislative vehicle to establish the palliative care councils. In recent years, we have also been very pleased to be working with the National Academy for State Health Policy, which has received funding from the John A. Hartford Foundation, to create technical assistance specifically tailored to state officials about what they should be doing to advance palliative care access in their state. You know, what we know is that every state is different in terms of what their priorities are, how many resources they have. So sorry, I don't even have water. And so it just, that impacts what is possible, what policy options are possible. And so when looking at ways to advance palliative care, often the strategies need to be presented as a menu. If you're going to be looking at doing quality or investing in the workforce or doing more education or doing payment, you know, some of these may be politically feasible, some may be infeasible. And so if states are looking to get involved, they need to have options that they can pursue. And so NASHP has been very effective in helping start to distill, you know, what are some of those options. So with all of this progress, what we observed is that we've been in an era of letting 1,000 flowers bloom. There's a ton of heterogeneity in state policies for palliative care. Like I said, how and where palliative care is defined, what are requirements, for instance, for physicians, like the Information Act, continuing education requirements, Medicaid reimbursement policies, and public awareness and stakeholder engagement policies. And that's wonderful. And now we're in a moment, because there's been so much progress, we were really finding that we needed a place to start to pull it all together, to say, is there a one-stop shop to share, to collect what has been done, and maybe start to think through what has really been impactful. And so with that, I will pass it over to Eugene.
Thank you so much, Stacy. Well, as Stacy brilliantly pointed out, there is so much that's going on across the state that we both have a moment of great opportunity in terms of policy innovation, but of potential risk, namely that there is such a wealth of information that policymakers, advocates, practitioners, and others in any given place might not know what the most innovative idea is anywhere else. We've seen this in the law and policy space for years. I mean, many Supreme Court decisions talk about the states as the laboratories of our country, testing out various policies to see what works, why. And palliative care, I think, is a perfect case in point. But how do we bring together all this information and innovation when there is so much heterogeneity? That's where our project enters the picture. The Palliative Care Law and Policy GPS came from our identification of this need. It was informed by work in other fields like climate law and environmental law, where burgeoning issue areas were filled with information from lots of different jurisdictions, lots of different states, localities, and so on. And until a centralized repository of information emerged, practitioners really were at a loss to understand how to advance the ball on any given issue. Our database, which I'll go into in some detail in a minute, aims to do three fundamental things. The first is to be able to provide a tool to track legislative and policy developments across the states, as well as additional entities like the Department of Veterans Affairs, the Indian Health Service, the territories, in real time practically. So through an innovative system of data collection, we hope to be able to provide a service that allows people to know what's going on in an up-to-date way. It also is meant to have a historical dimension. Currently, we're really moving from 2019 to the present, but we aim to expand backward to 2010. And that provides a kind of one-stop hub for information for viewers. But that's not all. The second thing we want this to do is to support innovative research so that interested policymakers and others can determine what policies work best and why. And the last piece of this is based off of the research that we hope this will support, there could be real policy innovation across this country. So that's the enter the GPS phase. Stacy, could you? Thank you. And so this is the landing page as it currently stands. We're continuing to tinker with this, but the idea is to allow people to be able to access developments across the country. States that are in deeper blue have more going on in them. The lighter blue states have less developments. And there's one thing I really want to point out here. We're not just tracking for policies, legislation, and so on that's been successful. We also are making progress on tracking policies that don't quite make it across the finish line. So one of the things you'll notice is that we track along a couple of different categories, not just things that have been passed or vetoed, but also legislation that's been introduced, and a few technical terms to the field like engrossed and enrolled, which basically means has something gotten through one house of a state legislature, both houses of a state legislature or not. And this comes from research in law and policy that shows that often the most innovative concepts are not ones that initially pass. They tend to be ones that were introduced somewhere else and failed, but were picked up in another state and advanced there in that context. So we wanted to make sure we could account for that. And this is how we hope people will be able to find out. Okay. So as mentioned, this is meant to be an online and publicly accessible searchable database. And our audience is broad. So we really hope that this could be something that would be used by medical professionals, policymakers, advocates, as well as patients and families, which was a big part of our design process, making sure that we have something that's usable and accessible. And as it currently stands, the GPS tracks for legislation in particular across the 50 states. As mentioned, that cuts across a variety of categories, not just bills that have passed. And it will aim, our aim is to provide something that's updated regularly and automated. But not only are we tracking across a bill status or the status of a law, we also are cutting across a variety of categories, 7 in particular. Workforce, looking at policies that support the growth of a specialty palliative care workforce. Payment, which monitors policies that expand financing or provide incentives to ensure access to palliative care. Quality and standards, wherein the states develop quality metrics and standards for palliative care. Clinical skill building, so increasing the capacity of medical professionals to provide symptom relief, education, and other services meant to improve the quality of life for people living with serious illness. Pediatric palliative care. So here we're tracking for policies that support the development and expansion of pediatric palliative care, as well as pediatric hospice. Telehealth, which certainly during the initial period of the COVID era had quite a lot of activity. That's policies that expand telehealth to allow healthcare delivery for palliative care virtually. And then public awareness. So policies that promote the public awareness of palliative care through things like advisory councils and public health campaigns, some of which Stacy mentioned earlier on in her presentation. As for the design and methods, so when we began this project, this was really from the ground up. We gathered a team of research assistants at Yale Law School, as well as later on partner institutions. And our students were trained along a variety of search terms to use one particular database, Lexis Plus, to search for statutes and legislation around these search terms that you see: palliative care, home care, long-term care, and so on. We also had certain exclusions, adult hospice care and medical marijuana being just 2. We did not go into administrative law regulations, essentially, though we intend to get there. Because this first stage involves quite a bit of legwork, building out legislative policy, we wanted to see what works and doesn't in that context before moving forward. And here's a very important part of our story. The students have been central to what we put together. Everything that they've done, they've sent to Stacy and myself, and we've been looking through their work. But this is extremely labor intensive, and the work that they've done, that labor time could be applied to research, analyzing the data that we gathered. To cut out that initial step, we partnered with StateNet, which is a long-standing research database that provides up-to-date information on developments, both in terms of legislation and regulations across the United States. It does so in an automated way. So we develop with them search terms and criteria that then generate a series of results that Stacy and I look through. And this essentially facilitates the ability to gather the information that's on the site while freeing us to be able to move into interesting research. And so in terms of next steps, as mentioned, this is currently focused on legislation. It basically takes us from 2019 on, and it's focused on the 50 states. But as we all know, palliative care policy plays out in many other ways across many other parts of this country. First, we want to expand legislation to 2010. The ACA really changed the landscape of palliative care policy, and that's partly why we chose that date to begin. We also think it's absolutely critical to include areas that have unfortunately been left out of many discussions around policy, not just in this space, but many others. That includes the territories, the Indian Health Service, and the Veterans Administration, VA. We'll move into state regulations, as mentioned earlier, and our hope is to ultimately also cover the federal government. And all of this will provide a platform for innovative research that will result, we hope, in helpful publications. And Stacy, handing it back to you.
So as you all can imagine, this has been a pretty ambitious project, and we've been building from scratch. And so we've learned a lot along the way. And again, I really just need to express my gratitude to the Solomon Center for Health Law and Policy, because the platform that you see, it was actually built from scratch, that they were able to program it and customize it, and we're continuing to finesse it, but it's really been a huge undertaking. So in terms of some of the challenges that we've encountered as we've been doing this work, I hope that this will elicit some chuckles from this group, but the challenge of what is palliative care? As Eugene mentioned, our inclusion criteria, there's certainly pieces of legislation that are very specific to palliative care and you know, like the standalone Medicaid payment benefits that are coming out. That's pretty clear cut. But then there are also a lot of policies that do impact palliative care delivery that don't necessarily have that explicitly laid out. And so as we've started this work, you know, we've come up with certain inclusion criteria. So if there is a continuing education requirement that physicians must receive 3 hours of pain management, does that go into the GPS or not? And so, you know, what really is the most essential, and that connects to the second challenge, which is sensitivity, which is what are the policies that we really need to be able to empower state champions to say, okay, I have what I need to be able to work effectively, or I need something else. I think to start, we have been overly sensitive, and the result is that even though we've only started at 2019, we already have hundreds, if not thousands, of pieces of legislation, which could be overwhelming to the user. So that's something that we're continuing to work on. How is it that we now start to work towards a more specific inclusion criteria, oversight and quality control. You know, similarly with StateNet, we're getting that much more information. And so currently the boots on the ground are Eugene and myself, and then the RAs. And so that's just so much information. How are we making sure that as we move to a place of maybe getting StateNet to automate some of the results that it's coming in, how do we have enough capacity to make sure that we're reviewing everything so that we have the right things going into the GPS? Obviously, we're also looking at some, you know, refining the tech and the platform functionality. It was built from scratch, but there are certain things that we'd like to see that we're continuing to plug away at. So if you go in and you use the GPS and you do a search, we'd love to be able to have some capacity to download those results into an Excel spreadsheet. Currently, we don't have things like that. and then capacity and participation. So, you know, we did a launch in August, and we're continuing to refine, but one of the things that we'd like to see in addition to on our side pulling out policies is that we'd also love to have a mechanism by which people who are working on interesting things in their states could come to us and say, hey, listen, have you seen this bill in, say, in Nebraska where I live? And be able to share that with us, and then we could have that uploaded so that it's not just us saying, you know, this is what we're pushing out, but also if people are working on something, then we could also add that in, you know, just in case there are things that we miss, because 50 states plus the territories plus the IHS plus the VA, like it's just a lot of information. And so we don't just want this to be our project. We want it to be the project of every palliative care champion who's looking to increase access in their state. So in summary, the palliative care state or the law and policy GPS will allow users to monitor and analyze how states are adopting policies around palliative care issues over time across the country, identify barriers to the adoption of policies on palliative care, and then conduct further research that will encourage policy innovation and development in the state policy arena. We have had wonderful folks on this project who've provided, you know, leadership and thought partnership to help get this off the ground. And then in the last 1 minute, we had some questions for the group, but I think let this be more open-ended. I think that's it.
Great presentation, Stacy and Eugene. In addition to your questions, Harriet added another question to the chat. Harriet, do you want to share it aloud in the last minute?
Yeah, I mean, this is amazing. And I'm also struck by the complexity of everything with such heterogeneity. And I'm thinking through, if you're kind of designing natural experiments to look at the impact of changes in state legislation on outcomes, I mean, that just feels kind of like a monumental task and yet a very necessary task. Is there a plan to kind of provide support for investigators in kind of policy analysis looking to use this data, or at least connect them to people who are kind of more enmeshed in the kind of policy analysis sphere? Because I don't know, I was speaking on behalf of all the other people on this call, but I think that would be really helpful to think through, how do we think about analyzing impact of policy in natural experiments, etc.
You know, Harry, that's probably the question, right? Because I think we've seen a lot of policies come through and we cannot speak to what has been the actual impact on the people living with serious illness in the state. I think the honest answer is we're not there yet, but we would love to be able to have some sort of way to understand what is the baseline or capture a baseline of where states are and then be able to use that. I think we'd like to get there, but we don't have anything yet, but it's a great point. Eugene, do you have any thoughts?
No, just echoing everything you said.
Yeah.
It's a great point.
Thanks everyone for being here. We're at the top of the hour. Great presentations. And we will see you all back in 2 weeks.
Thanks,
So if you do have any additional thoughts, please feel free to email them to us, because we do actually want answers to those questions. So
Stacy, if you want to just send the questions out, I can follow up with the list.
thanks, Caitlin.
Fair.
Bye.
Bye, everyone.